All right, I was just sharing with the panel before I get started. I didn't want to be shouting into the microphone before we formally started, but I hope everybody enjoyed lunch, making sure that everybody is in the right room. So we will be talking about strategies that meaningfully address social determinants of health. My name is Jessica Hampton. I am the Enhanced Care Management and Community Supports Manager for Central California Alliance for Health. Very long name. We also go by the Alliance. We are the managed care plan in Santa Cruz, Monterey, Merced, Mariposa, and San Benito counties. And I am joined by a very exciting panel today, and so we will all be talking about the different ways social determinants of health are being addressed. So, as an opportunity to kind of set a foundation, social determinants of health are something that allows us, and this really resonated with me this morning, and I was sharing with some of my coworkers that coming to things like these types of conferences really help to reaffirm and re-inspire why I do what I do. And so social determinants of health really help to put the person back in person-centered care. So it's no longer just looking at their specific clinical outcomes, but understanding those non-clinical factors that have such a huge impact on their health outcomes. So addressing food insecurity, looking at housing insecurities, understanding the impacts of oral health, understanding even different accessibility for different people. And so social determinants of health for the first time are really being addressed and driven through some of these CalAIM initiatives. And so I am going to echo what I have heard throughout today. It is exciting, it's inspiring, it's transformative. These things really give us an opportunity to impact people and meet them where they're at and start to look at what is impacting health beyond, again, your classical, clinical aspects, really. And so, again, the panel today is going to be discussing some of those strategies. As a managed care plan, what we are starting to do, and so the Alliance is adding things like community supports, which is a CalAIM benefit. And those community supports, there's actually 14 different community supports that are currently being offered, and they address a variety of social determinants. So there are things like medically tailored meals that are looking at food insecurity. There are supports that offer housing. So there's housing transition and navigation to help support people getting into housing. The Alliance is also committed beyond CalAIM and have done things. Our community engagement team is currently doing health equity tours and partnering with our community to really get an understanding of what are the needs in the community, what does health equity look like from our members' perspective, the people who live and work in those areas every single day. Also doing things like HIP, and so looking at grant and funding opportunities to support housing and homelessness, and looking at different vaccination clinics and meeting people again where they're at. So it's very exciting to see social determinants of health be part of the CalAIM initiative and be a topic of conversation in the broader healthcare space. I will now hand it over to Francine to introduce herself and just talk a little bit more about what she does.
All right. Thank you, Jessica. I hope you can all hear me. I'm Francine Foley, and I'm the Executive Director of Golden Valley Health Center Foundation. And Golden Valley is a federally qualified health center in the Central Valley. We're in 3 counties. We're in San Joaquin, Merced, and Stanislaus County. We serve over 145,000 patients annually out of 45 to 47 clinics. About 70% of our patients are Medi-Cal. We serve about 25% are farm workers. So we have a lot of specialties, pediatrics, adult health, dental, podiatry. And our services are given with dignity and respect. And I've been there for about a year, and I just absolutely love it. So the foundation's mission is to support the projects of Golden Valley and support our patients and our families. And so we're really interested in the social determinants of health, and especially how we can help our patients in person-centered care. We realize that health outcomes are better if there's not just medicine that's being given out, but really giving out care for the entire person. So I've been in nonprofit work for about 25 years. When I got to Golden Valley, I called Second Harvest of the Central Valley, and they are our local food bank. And I said, I'm at Golden Valley. They said, we have a health center grant. We would love to do something at a health center. So I said, well, why not? We'll do that. So to start off, we surveyed about 200 patients to see if there was a need. And of course, we found out that 25% of the patients that we surveyed did have food insecurities. The next step was to find a place to hold a food clinic, and we went to one of our busiest clinics, and they happened to have because we needed room to keep shelf-stable food. They happened to have a pharmacy that was vacant, and that's how the food pharmacy was born, because it was the food will be given out through a pharmacy. We don't really market the project. How we go about getting food to people is all of our patients are screened. So everybody that comes in is given a questionnaire. They're asked within the last year, I was worried whether our food would run out before I got money to buy more. Second question is, within the past year, the food I bought didn't last and I didn't have money to get more. So they answer always, sometimes, or never. I hand that to the medical assistant. She looks at it, and she actually, if she determines that there is a need for food, she actually gives them a prescription to go to the food pharmacy. And it has refills on the bottom, so they don't have to go back to their provider. They can go back for food every week if they need it. And on the prescription, it shows the location and the time of the food pharmacy, which we're open 1 day a week from 10 to 1 at the site. Then the patient comes in, they give the prescription to our community health workers, which they are our heroes. I'm telling you, they are phenomenal in what they do. Seriously. They run this single-handedly. They really are my heroes. So a patient comes in, they hand them the prescription to the community health worker. The community health worker gives them a bag of food, which is about 15 to 20 pounds of food. And it's shelf-stable, canned fruits and vegetables, rice and beans. We change it up every week if we can. Peanut butter, chicken, tuna, we try to keep it really healthy. And the food pantry referrals, we give other referrals to the communities in case they need food in between, and some nutritional information. So I started with one site serving one clinic, and that was in April. I opened a second site, West Modesto, and it's serving another clinic. So we have actually 2 hubs with 6 clinics that are accessing the food. So the patients can either walk over from across the parking lot from the other clinics or drive over. So we're serving quite a few people. So you probably wonder how the bags magically appear at the food pharmacy. Well, Second Harvest actually has volunteers that pack our bags for us. And I'm lucky enough, my son-in-law works for Amazon. So we have a trifecta of organizations doing great things. So we've got Golden Valley, who has the patients and the way to distribute the food. We have Second Harvest of the Greater Valley, which provides the food. And then we have Amazon. And what do they do best? They deliver. So my son-in-law delivers 400 boxes to our sites every month. So it's a great collaboration. It saves the food bank transportation dollars, and it gets us going. So I wanted to share some numbers with you, and they're kind of impressive. So we started the food bank at Florida Avenue on April 23rd. We opened our second site at West Modesto in October. And today, from April to December 31st, we gave out 1,998 bags, serving nearly 8,000 people. Our family sizes are around 4, so we know that's how many people we served. That's 38,000 pounds of food. And I just want to kind of give you a visual of that. So I like to travel, and when I travel, my suitcase is really full. It's the biggest suitcase on the airplane. It's 50 pounds, right? So that's 761 Francine suitcases, just so you know. So you can get a visual on that. And this is all funded by Second Harvest. They have this grant. So the in-kind amount is over $73,000 that they have provided to Golden Valley and our patients. I also started a food coupon project in Merced with a nonprofit called the Community Initiative for Collective Impact, and it's funded, thank you very much, by the Alliance. And we give out food coupons, which is much easier. So we screen patients the same way. Anybody that has a food insecurity is allowed to come once every 2 months. They're given $20 in coupons. One's a $10 coupon for produce, and the other is a $10 coupon to go to the grocery store. So in 7 weeks, we've given out 359 sets of coupons. We had people lined out the door during the holidays, so it shows a huge need. And recently, just this last month, I finished a survey. Dun & Merced, we've surveyed 1,234 patients. And of those, 528, or 42.5%, said they needed food. So when we started, our patients said there was 25% needed food. It went to 38% at West Modesto. Now we're at 42.5. And we all know how expensive groceries are. We go to the grocery store, so I can imagine how hard it is for people. So we're addressing care gaps. Patients are getting better care, they're healthier. Our physicians, our providers really want us to continue our work and also maybe do some literacy projects for children too, so I'm working on that. But I want to end with a couple of stories because to me, stats are great, but I think some stories are even better. So one of our physicians called me, and when a young mom had come into her clinic, and when she did some tests on her, she found that she was spilling ketones. And she asked her, "Are you eating?" And she said, "Well, I don't have any much food, so I give it to my kids." So she called me, she goes, "Can you get her some food?" Brought it over there. The next week she came, she was fine. So it really works. And my favorite story is we had a grandmother that came into the food pharmacy. She had a walker. She had a little 6-year-old granddaughter with her. She goes, "How do I get one of these food bags?" And so the community health worker said, "Let me help you." So she said, "Are you in need of food today?" And the little girl goes, "Yes, we need food." So she said, "Okay." So she handed her a bag of food, and inside it was a huge box of cereal. The little girl looked in that bag, and she looked up, and she said, "This is the best day ever." Over a box of cereal. So we know we're doing the right thing. We're excited about it. And last night I attended the meeting, the dinner, and Dr. Bob Ross from the Calendau, he was so inspirational. And he said that all of you out there, all of us, are doing such great work. We're investors in hope. And I want to think that that's what the Food Pharmacy and Golden Valley Health Center Foundation is for people, investors in hope. So.
Okay, what a great story. Thank you so much for sharing. I love food pharmacy concept. At Asian Health Services, we do some food distribution, but not the same way that you do. So congratulations on that. If you were here yesterday at the reception, you heard Dr. Ross said that 23 years ago, there was 1 out of 4 residents in California, had health care. So the other 3, didn't. The studies that I've looked into, it shows that for every 1 resident of California that is without medical insurance, there are 3 without dental insurance. I am Hoon Lei, Chief Dental Officer at Asian Health Services. I've been there for over 20 years. Asian Health Services was founded in 1974. So yes, this year is our 50th anniversary. Thank you. So the Community Health Center, although it was founded way back in 1974, it wasn't until 2001 when they gather about 400 patients at a general membership meeting. Our patients are referred to as members. The leadership team basically asked the members to come together to ask them what they could do to help. One of the patients stood up and said, "How can I have good health if I don't have good teeth?" So that was the reason why Asian Health Services decided that yes, we do need a dental program. So they obtained funding, fundraised, and they asked me to come to become their first dental director, and this was in 2003. When I came, I did tell them that I wanted to make sure that our patients were taken care of as a whole person and not just you take care of the body and I take care of the teeth. I said, that's not going to work. So thank goodness, at this point in time, we do have a very robust integrated care model that I hope to share with you later on. Our patients population is primarily, Asian. I would say that we have about 85% that are Asian immigrants, and the rest are, of other, ethnic groups. Our staff speak 15 different Asian languages. And we do a lot of outreach to make sure that our patients, have the ability, to receive care in a very culturally competent, way. During COVID, of course, it was very challenging to both medical and dental and behavioral health, as you know. But we were able to serve 50,000 patients during that time. I'm proud to say that Asian Health Services is the first dental clinic in the country to screen depression in dental program. And not only that, I also hired a licensed clinical social worker to work in dental. So our patients could get the counseling when they need it, as they need it. And I will share with you the stories why I wanted to do that. 2019, we also started a new program, and that was diabetes screening. And we conduct hemoglobin A1C test in dental. And we refer our patients to medical if they are identified as someone who are at risk. So with that, I'm hoping that, later on I could share with you some stories. So as you can see that we are a healthcare facility, we recognize that the patient's health is directly linked to their social and economic circumstances. And that's why we are dedicated advocates. We promote policies that make sure that our communities are a safer and healthier place to live. So with that, I'm going to end, and I'm going to turn it over to Joanna.
Good afternoon, everyone. My name is Joanna. I'm the Director of Community Care Coordination at 211 San Diego. For those of you who may not be familiar with 211, 211 is a public utility that most of you guys should have access to. There's actually 99% coverage of 211s across the country. 211 San Diego, we are a hotline that any individual can call into and get access to social services. I've been at the organization for a little bit over 7 years now, and I'll be talking a little bit today about the Community Information Exchange. In case you guys aren't familiar with the Community Information Exchange, that is an ecosystem, a technology platform that allows different partners to have access to client data. So we currently, in the Community Information Exchange, which is kind of under the 211 umbrella, we have about 130 partners that are all contributing different levels of data for Medicaid patients who are accessing different social services. And then the work that I do within the organization, so I work under the Community Information Exchange in relation to community planning, identifying which provider should be part of that system, how we get data to integrate from different systems so we're not all having to log into different various systems like the HIE, the CIE, the managed care plan system, and really thinking through how can we integrate that into one system so that this network of partners has access to the same data, and that data travels as clients access different services. So I do that work, and then I also provide direct oversight to some of our direct services. So my team also is an enhanced care management provider under the CalAIM program, and then we also have a partnership with the County of San Diego where we are receiving referrals from the Child Welfare Services Department for families that are at risk of CWS involvement. So those families come over to us where we try to address what their social determinants of health are, connect them to different resources with the goal of preventing them from having another call made into Child Welfare Services and hopefully not have that investigation happen within that household. That is all.
So Francine, now that you've mentioned you were able to provide 720 Francine-sized suitcases, I'm sure we all want to know, what does that look like? So if somebody wanted to start a food pharmacy in their own community, who should they be engaging with? Who in the community in terms of stakeholders? Who also as in terms of community-based organizations should they be engaging with?
Well, the first thing would be to assess the need. We don't want to tell our patients, you need this. Would they rather have a food box? Would they rather have, we're looking at medically tailored food come down the line a little bit. Would a food coupon be easier? What would be the best thing? So we actually are surveying now for that. So find if there's a need within your clinics or your organization. And then the first thing is reach out to your local food bank. They are an amazing resource. A lot of them, like Second Harvest of the Greater Valley, have grants that they are looking for people to provide funding for. Reach out to your health plans, ask them for support. A lot of them have funding for that kind of project. We have volunteers that help. At one point, we were packing bags. We had volunteers that came and helped hand out bags. There's utilizing rotaries and things like that for people to come and help you in those projects. But really, just engaging your providers to get buy-in, and your operations managers at your clinics. Do they find it's necessary? Do they find it's going to help their patients? And we make it really easy for the clinics. We don't add a lot of extra work. It's just we take on a lot of the data tracking and that, so that it makes it easy for them. So really, it kind of takes a village to do that. But really, reaching out to your nonprofits in your community that have food sources for you would be helpful.
And then Joanna, so in terms of CIEs, what advice do you have for counties that want to leverage their own CIEs or other data systems to connect people in their communities with things like CalAIM or other supportive systems within the community?
Yeah, so I'll just say that the community information exchange takes a lot of time. So when I started at 2-on-1 about 8 years ago, we were just launching the community information exchange. And in the past 8 years, we've grown to having a little over 130 partners that are all contributing to that data. We're also integrating data from systems like the Homeless Management Information System, which has been a really big win, so that so that we all have access to the same data and can see who's accessing services with which providers to help with some of those care coordination efforts. I would say that the biggest thing is when you're starting a community information exchange is to make sure that you have all the right stakeholders at the table when you're in those planning sessions. And I would also say that to not hold yourself back if you aren't able to get all of the stakeholders. Do your best in trying to get as many stakeholders, that includes social service agencies, healthcare agencies, government agencies, all at the table to start planning and really identifying what are the needs, what are we trying to solve for, and what is the use case that we're trying to really build this system for. I would say that that's probably the first thing. And then obviously identifying that funding to be able to do it. We at 2-on-1, kind of all of our stars aligned at the same time, where we just got a couple different buckets of funding that allowed for us to create this system. For those of you who aren't familiar with 2-on-1s, typically, when you at least back in the day at 2-on-1 San Diego, when you would call in, it was an anonymized record. So you would call in, it was anonymous, you would provide somebody with a referral, and then we never knew, what happened with that client. Did they get access? Did they have a barrier? What was the outcome of that resource? So that was something that was, we realized was really holding us back from serving the community in the way that we wanted and needed to. So that's when we created essentially a longitudinal client record that came with this community information exchange backbone that allowed for us to have this integrated system with these different partners. Along with the system comes, we have 14 different assessments and the different social determinants of health. When someone calls into 2-on-1 and they state that they have a housing need, we're not just giving them a referral. We're doing a full assessment to really understand what is the immediacy of that need, what are your what are your current supports, what are your current barriers, and then how have you been accessing resources? So we're doing this assessment to really try to understand what is happening, and then be able to provide that resource, and then track that information, and then see, does that client call back in? Did they get access to that resource? How did that resource work out? Did they have a barrier? If they have a barrier, how can I help address that barrier? Is that barrier transportation? Can I get them a Lyft ride to make it to the WIC office so they can pick up those coupons for their children to get access to that food? So I would say, just make sure that when you're building a system, it's a complicated system. It's a very complicated, trying to integrate all these different systems. There's a lot of politics involved in that, unfortunately, but if you start at the table with the right stakeholders who have the same passion, I think you can definitely accomplish it.
Thank you for sharing. And then Dr. Lee, if you can let us know what led you to become such a champion of oral health and integrated care, and then how others can do the same within their own organizations.
Okay. Well, thank you for the question. And instead of answering the question, I'm going to share you some stories. So maybe you can draw your own answers on how.
Be my follow-up question. She jumped the gun.
On how and why I do it, or why I did it. So I had a 16-year-old patient who was in foster care. I finished all of her fillings, and so just like, every patient, I would say, hey, hooray, you're done, carriage free, just make sure you brush and floss and come back to see me in 6 months. So her answer to me was, no, you're not going to see me in 6 months. I asked her why, and she said, well, I'm going to go home and commit suicide. Then we had a middle-aged male patient that came to the clinic one afternoon unannounced. He didn't have a visit. He just showed up, and basically he walked around thanking all of us for all the care that he had received. And he said, you know what? Thank you so much. You guys have been so nice to me, and I've got all my, cavities taken care of, and I just want you guys to take care of yourself. I just came back from my medical doctor's office, and I found out that I am HIV infected. So we basically, and that you should probably get yourself checked out. So we said to him, it's okay, we're really sorry, but it's okay, don't worry about it. There's treatment, and I'm sure that you can get the help you need. And so he goes, well, I hope so. So the next morning, we came back into the office, and then we read the newspaper. We found out they had committed suicide the night before. So then we said, oh gosh, what could we do? We are at a community health center. We have primary care. We have behavioral health. What could we have done for these patients? Okay, so now you can see what motivated me to do this. So then when we started the depression screening using the same form that medical department used, the PHQ-9. The first day, of course, I had to get the approval, from my leadership team and from my CMO, and had a conversation with my behavioral health, manager and all that. So we were all everybody was supportive, of the program. So we were the first, as I said earlier, the first community health center in the country to do this. So then the very first day, we went through all the training. The very first day, a patient came in to fill out the PHQ-9, and she wrote on the form, I'm contemplating suicide. Okay, so we said, okay, so this is good. This is good, So anyway, moving forward, we started the screening like about 2015. 2020, as you all know, COVID hit. April 2020, I got a call on a Sunday from the daughter of a patient who was in counseling at the dental clinic. And I remember her very vividly. When the way that we do it is that all the patients that come in is given a patient intake. In that patient intake, and we actually do everything digital. There would be medical history, dental history, notice of privacy, everything, And of course, PHQ-9, and then now the diabetes screening. So anyway, I still remember very vividly this patient. She refused to fill out the PHQ-9. And in fact, she got very upset at my staff for asking her to fill that out. And she said, what are you trying to say? Are you trying to say that I am mentally ill, that I am depressed? I don't. And I'm going to sue you for telling me that I'm depressed, that I have a mental issue. She did that just in November of 2019. So I talked to her and I said, you know what, it's just a screening form. You feel free to fill it out or you don't. It's okay if you don't. We're fine with that. So she filled it out, and she had all the signs indicating that she was, depressed. So we were able to get her into our counselor, to be seen. This was November 2019. April 2020, her daughter called me on a Sunday to tell me that she was just out of control and that the family was about to call the police to put her in a 5150 hold. So immediately I contacted my counselor. We talked to her. together, and we were able to get her, some counseling, and we were able to get her on Monday into our specialty mental health. Okay, so we had also another patient who lost his mom, and he was 40 years old. He was in major depression. Got him into care as well. In fact, there was a news, there was an article, a publication about his story. Same thing. And he basically said, "I'm so glad that I went through this, counseling." I have a 16-year-old patient that said to my counselor, now she didn't tell me this directly, but she told my counselor, "I'm so glad that I can receive the mental counseling in dental, because when I tell my parents I'm going to dental, they don't ask me any question. They think I'm coming here for a dental filling. But when I told them I was going to medical, they always asked me why." So that right there could tell you that receiving counseling in dental clinic basically removes all of that stigma. No one would ever expect that you would be receiving, counseling in a dental clinic. Okay, you go there for fillings, you go there for cleaning. So anyway, those are some of the stories related to the depression screening. 2019, we started a new initiative, and that was diabetes screening. And we decided that, there were so many patients that we see in dental that are diabetic, but they're not sure how their diabetic condition is. So we decided that, okay, well, let's do this. Besides checking the glucose, let's do the hemoglobin A1C to see how stable the diabetic condition is. So we conducted, and the story I will share with you right now is this. Within just the first year, we had over 30 patients that were diabetic that were not aware that they were diabetic. We had one 19-year-old patient that was scheduled for oral surgery with our oral surgeon. Our oral surgeon decided to test him for hemoglobin A1C. His hemoglobin A1C was 12.7. Now, for those of you who know the hemoglobin A1C level, anything over 7 needs attention. Anything over 8 is considered as uncontrolled. This kid was 12.7. So, of course, we abandoned the surgery, referred him to his PCP. He was able to enter care under an endocrinologist, which he should have been all that time anyway. So these are the success stories, and these are why I become a very strong advocate, and not only that, a believer in the integrated care. Dentists should not be doing drilling and filling, and that physicians and dentists should work together to make sure that our patients are being taken care of as a whole person. Remember, the mouth is the port of entry to the body. Okay, everything has to go through the mouth first, unless you are being tube feeding, okay, or fed, or whatever. But anyway, but seriously, I think a lot of times that our physicians and even, our dentists, we're too busy taking care of, of dental disease and all that. We don't think of the patients as having some other underlying medical conditions that could actually affect their dental conditions. And our physicians don't think about, how dental treatment could actually help improve, the patient's, medical conditions. So, so after all these years, I've been a dentist for 40 years now. After all these years, I strongly believe that this is the way that the future integrated care model should be.
Dr. Lee, thank you for sharing so many amazing stories. And I think it just really highlights it takes a village. It takes all of us together to meaningfully address social determinants of health. I have a two-part question for all of you, so whoever wants to answer first, by all means. The first is, what are the biggest challenges in implementing your different programs? And then the second one, and specifically when we're talking about challenges, how are you expanding these services to serve more people? And then the second question is, what are some of the biggest challenges in sharing what you're doing with the community and being able to have these resources available to a wider group of people? And whoever would like to go first.
We all want to go first here, I can tell. As far as expansion, of course, you know, location and also funding is always a hindrance, but kind of using the model that we have by having a hub with clinics that feed into it, I think will be helpful for that. But that's probably the biggest challenge is, as you expand. And we have 47 clinics, and everybody wants a food pharmacy. So, you know, and then we want to do other projects also. You know, our pediatricians are looking at bringing the Reach Out and Read program, which is just amazing to me, to have pediatricians that are so caring that they want the children to be able to have books to read. So how do you implement all these programs? But, you know, I think part of it is you just act. Instead of asking people, do you need food, and then say thank you for that answer, give them food, you know. And I feel like that's what happens a lot when we ask these questions, you know, or are you depressed? Sorry to hear that, you know, that, and you don't do that, you really act. But I mean, so when I got to Golden Valley, they said, well, we've wanted to do this, but nobody it kind of fell together. And I think really just act sometimes, just act.
Yeah, you know, as far as like, you know, for us, you know, as you know, we are so used to working in silos. Like, you know, medicine works in medicine, behavioral health works in behavioral health, and dental works in dental. And although we are under the same roof, many times the communication doesn't exist. So I would say that, you know, for those of you who want to establish something like this, you know, first of all, you need to have a vision. You need to know what you really want to do and what it is your goal, what your goal is, and then talk to talk to other departments, you know, and I can tell you when I started the depression screening, it was just it was a meeting between me and my chief medical officer and the behavioral health manager. And there was absolutely no issue at all whatsoever. We were developing a curriculum for our geriatric patients. Asian Health has about 35% geriatric patients. So we were working on developing a curriculum, you know, for our patients. So that was not an issue at all. But that was back in 2015, 2016. 2019, we had different medical leadership. So when I brought up the idea of doing diabetic screening and hemoglobin A1C, I did face some challenges. My medical directors didn't want to do it. And basically they asked me why I was doing it. And so I had to work with them through some of the barriers. And we, you know, it didn't take long though, to be honest with you, it didn't take long. But still, I had to be open to their concerns, you know, and we talked about it and we developed a system, a workflow, so that they don't have to be fearful of me taking over their job, because I don't. Basically, I just tell them that I'm screening, I'm not diagnosing. I have to, you know, so we came up with an idea, like, you know, okay, if the hemoglobin A1C of the patient is within this range, we refer the patients to nutritionists. If it's at this range, you know, which is 6.5, which is really what medicine uses, you know, to, you know, as a benchmark, you know, for the diagnosis, then we refer those patients to their PCP, you know, for further evaluation. We never tell our patient, you are diabetic. We only tell the patient, we do the screening, and this is what your value is. You need to go see your physician to get further testing and evaluation. And that's what we tell them. And that way, there's no threatening, you know, whatever. So anyway, so that's how we did it. I think it has a lot to do with trust. It has a lot to do with communication, and like as Francine was talking, like food. Patients need to have food, but they need to eat the right food, So I think that's all incorporated in this whole, system. Licensed clinical social worker, I love my social worker. In fact, I'm thinking maybe in my next life I will be social worker. And the way that we work it out is that in our dental clinic, the label on the outside of the counseling room is not counseling room. We actually label it consultation. So patients that walk right by it have no idea that counseling is taking place behind that door. They think it's a consultation. So that's how we do it, try to, and keep it simple, start out small, and then go from there.
And I think from the perspective of the community information exchange, I think the biggest challenge is that it is another system. And us as providers, we already are logging into so many different systems to get different access to information. So trying to get another partner to log into another system is definitely our biggest challenge. That is why we try to work so hard towards data integration and working with these other systems to really be able to integrate their data. Like I mentioned already, one of the biggest wins has been integrating homeless management information system data and having providers have access to that so that there is that elevated level of care coordination for those individuals. And then also people are kind of hoardy with their data, to be honest. They don't want to give it away. There's lots of, liability issues around health protected information, and people are really, really nervous about that and releasing that information. So those are things that we're constantly, battling and working with providers to give them that ease that, our system is confidential and it's HIPAA protected, and also provide them with, different reasons why they should go into our system, and what is the value of our system. And one of the more recent work that we've been doing related to CalAIM is really trying to get more CalAIM providers in the system to be able to accept direct referrals for those systems. For those providers. If you guys don't know, in San Diego, we actually have 4 managed care plans, which makes it really, really difficult to help navigate members in San Diego County to CalAIM services because each managed care plan has a different process. So really being able to leverage our system and have this kind of one no wrong door way of getting access to CalAIM services directly to providers that are out in the community to help with screening and enrollment in those services is really key. So we've been running some CalAIM affinity groups these last couple of weeks, actually, where we're inviting some of the big players in the county who are providing CalAIM services, and we're bringing them into a meeting to talk through, how do you currently utilize community information exchange? How do you wish to utilize a community information exchange? What data is valuable? What data do you want to see there? And then really support them through different workflow designs to help integrate the community information exchange into their overall workflow, and then really listen to them about, where are the gaps and how can we address those within our system. Thankfully, San Diego County is a very collaborative county. We have a very, very strong relationship with the county of San Diego, where we work really closely with them to really try to problem solve these things. And then also through CalAIM, we've also been able to leverage some of the funding that's come through CalAIM to allow for us to really build upon some of these processes within our system and really utilize our system in the way that providers are saying that they want to use it, and using those CalAIM dollars to make the use case for that, and then essentially build that in our system through those dollars.
So we have time for questions. So if anybody has any, that was immediate. That's fantastic. I'm just checking. He's bringing the mic down just for you right now. So.
Hi, my name is Abraham Husseini. I'm a medical scribe serving the FQHC Livingston Community Health, so your sister FQHC, Francine. But I just want to collectively thank the whole panel for the incredible work you guys have been doing. It's very inspirational, and I love how forward-thinking you guys have all been. My question to the panel is on behalf of the medical providers I scribe for. How best can we sustainably address the social health needs of our patients? Many providers feel overwhelmed, unsupported, and unequipped while advocating for patients in need of support.
Yeah, so when I started depression screening, I did get some resistance among my providers. I have over 20 dental providers working. It's like, why are we doing this? This is how much it's going to take, And honestly, I had thought about it, and I worked on the workflow with my licensed clinical social worker. I include the, the depression screening and also the diabetes screening form as part of my patient intake. So when the patients come in, they fill out on the iPad, all of those forms. It's just like another 2 forms that they have to fill out. Just click, click, click. They'll just basically check off, boxes. And it was very painless, honestly. And we have all those forms translated into different Asian languages for our patients, too. I think it's one thing to have the vision. It's another thing that you have to make sure the workflow does work and it doesn't create much work, And then I had the licensed clinical social worker train my staff on how to interpret, the results and how to. And then we have the workflow for the referral process, and it's all electronic. And so anyway, like one match, when everything is in the digital check-in, it's all uploaded into the medical record, and then our manager will go in and basically make the referrals as needed. So everything gets flagged, and it's one of those things that you have to be respectful of your provider's time as well. And the last thing I want to do is really slow them down. And to be honest with you, we started those 2 innovations. It has not slowed us down at all. But I think it has a lot to do with the fact that we do check in our patient digitally, and that helps. And even with paper form, I think it's just a little check boxes, so I think it's still okay. I have gotten no resistance for the diabetes screening at all. I did with the depression because at that time, to be honest with you, I think my providers didn't really understand, why we needed to do depression screening. So I think it was a little bit harder for them to understand. But with diabetes screening, that's easy because they understand that affects the outcome of the dental surgery. So they accepted that right away, no problem. But the depression was a little bit more tricky.
Any other questions?
Hi, I'm Peg with Covered California. I just want to say I think I chose the best room. This is some awesome stuff. I'm curious to know how we can get more dental providers to do what you're doing, because it's funny now. I'm thinking about this. My husband's going to the dentist today, but every time I make him an appointment for a primary care provider, he'll cancel that, but he'll go get his dentals checked every 6 months. So if we could just get you guys to all do that, I think it would solve a lot of care gaps.
Well, thank you for sharing that, because I think I see that too. I do think that dental providers have a great opportunity, to see, and it's true. Patients, and that's the funny thing is even at a health center, the number of visits per user is higher in dental, compared to medical. So that tells me that the patients do come into dental more often. We actually have more patients that sign up to become our members, and they would specify dental only because they only want to be seen in dental. And I think it has a lot to do with the fact that we do have 4 specialties on site, so they don't have to go, somewhere else. But, and also remember, the dental visits are much longer than medical visits. Medical visits are 15 minutes, whereas dental visits are usually 30, 40, 45 minutes or even longer. So I think we have the time to do that. And I think that's one of the reasons why, but I do think that dental providers or dental clinics that want to do it, they should reach out to some of us, that are doing it already, and maybe we could share with them, how we do it to lessen the pain of starting something new.
Any other questions? Okay. Oh, there's a few.
Hi, my name's Rob from Placer County Health and Human Services. So maybe my question is more for Joanna, but for the whole panel. We were actually the largest county in California without 211 service up until about 3 years ago, which we implemented. And in the midst of COVID, which really provided an incredible, as kind of speaking to the choir here, but preaching to the choir, but an incredible amount of service, especially during crisis, to our community. But I know there are some communities that are actually going back and losing 211 service largely because of funding. And I'm seeing this as we kind of advance with things like community information exchanges, is just having this from a health department's perspective to have one point of access for this really, as we talk about CalAIM and all these, it just gets more and more complicated, right? Although we're enhancing the benefits, it's just really complicated for me to understand, much less to explain to the patients. I'm a psychiatrist, so the patients that I serve. So any thoughts, especially specifically, I'm excited to hear about utilizing CalAIM funding. So maybe we'll talk later in the details. But any ideas about how do we fund CalAIM and other kind of data opportunities for people to access these services, but also for health departments and others to get that data to see where are people going for these important services. Thanks.
Yeah, I think through the CalAIM initiative, it's been really beautiful to see the merging of health and social services finally coming together and all starting to speak the same language around what patients' needs are. So I think that through CalAIM with some of the incentive payment program funding that became available, that really allowed for us to make the case to managed care plans, the value of our data. So for those of you who don't know, there's about 1,000 to 2,000 people who call into 211 every single month trying to get access to services. And like I mentioned, we're assessing them in all of these different social determinants of health areas. We're not just giving them referrals and calling it a day. We're really trying to understand what their needs are. So the managed care plans have actually been coming to us since the rolling out of CalAIM and asking us for our data. They've even started paying us for our data. So they're even paying us for per member per month. All the members that we have in our system that are of this managed care plans, those managed care plans have now started paying us to receive that data, because managed care plans and the health system hasn't known who's been homeless, hasn't known what people's social determinants of health are. And now they finally are interested in that, and they're finally coming to 211 and asking to provide them with that data so that they can identify the populations that, their members who have the highest needs and who are, critical for receiving those ECM services and those community support services. So I'm really confident that, there's going to be more funding made available throughout the state as we become more progressive in this area of social determinants of health. And I'm hoping that, I know that there's been 211s that have been kind of, been merged by other organizations and have been kind of losing that, that human touch of, now it's, AI systems that are now answering those calls, which is really, really unfortunate. But I'm hoping that we'll get back to a place where the community and the state is seeing the value in having these human one-on-one interactions where we are really assessing these areas, and then and that value to providing that back to the healthcare system to really identify those critical individuals who need access to these services.
And I think we have a question up here at the front.
Hi, this panel has been amazing, especially as someone that comes from the Family Resource Center world and community-based organization. I'm Jenna Balahai. I'm with Yolo County Children's Alliance. I'm also the chair of our local COC in Yolo County. So this question is for you, Joanna. We've had some talks about integrating 211 into our HMIS system, but there's some resistance to that, because, like you said, people kind of hoard their data, and there's a lot of compliance issues with HMIS. How did you what was the steps that you took to convince people to do that? That was my first question. And then my second question is about the community information exchange platform. What platform are you using as a county?
Sure. So I think that honestly, for how we were able, so we're integrating HMIS data. In our county, the HMIS system would never integrate our data because it's way too much data for them to ingest. So we're integrating kind of the most basic data from the homeless management information system. Honestly, I think a big reason for why we were able to accomplish that is because our partners in the community were demanding it. They were demanding it from the HMIS system. They were demanding it from our local COC to give us that access because we were seeing more and more of those big housing providers accessing CIE, having lots of issues with the HMIS system and wanting to have just one place where they could go with all of the data and all of the information. So it was really our partners that were coming to the table and really saying, you guys need to work with 2-on-1 and create some sort of integration or create some sort of relationship. Otherwise, like, we aren't going to be able to continue to provide these services. So I would say that, you know, that's been really our huge backbone of all the work that we've been doing has been those partner relationships and fostering those and having really them be kind of our champions. Because, you know, I can say all the great things about my organization and the community information exchange, but I think it means a lot more when it's actually coming from a partner who's leveraging it and utilizing it and seeing the impacts of it and seeing the outcomes of it. And they oftentimes are the ones that are kind of speaking on our behalf and really fighting for us to create those partnerships. In terms of the platform, so 2-on-1, our CRM is built off of Salesforce. Our partner portal is also Salesforce. We're also building a client portal. We're also creating a separate client portal that clients will have access to, and they'll actually have access to their own data and be able to make adjustments to their own data. They'll be able to revoke their consent to have their data shared. They'll be able to directly refer themselves to resources. That, however, I don't know what system that is. I'm sure it's like an app-based system. I'm not entirely sure, but our partner community and then our internal CRM is all off of Salesforce.
So I just want to thank everyone for attending. I want to thank our panel this afternoon just for really highlighting the importance of collaboration, innovation, and acting. So it's not enough to just think these things through. We have to work together. Again, it takes a village. So thank you all. And if we can just take a moment to give them a round of applause. And before you leave, if you can just take a second to submit an evaluation of this session, that would be great. And thank you all for the work that you're doing. Again, it takes a village, so it's exciting to see people that are excited to get this work done. So I hope everyone has a great rest of the day.